Hello, Dr. Awar. Today we shall start to talk about blood and tissue protozoa. You have studied the luminal protozoa with Drs. Matar and Dr. Haj, and today we shall go on with the blood and tissue protozoa, which are unicellular organisms. Like you see in the middle of this slide, they are structurally equivalent to a single eukaryotic cell. So they are unicellular organisms, and that cell of the protozoan parasite is a eukaryotic cell, which means that it has got all the cellular characteristic organelles inside, especially the presence of the nucleus, the mitochondrion, Golgi apparatus, and other components of the cell. This is in comparison to prokaryotic cells, which are the bacterial cells, where they don't have a nucleus, rather the genetic material is floating within the cytoplasm. So here we have got those eukaryotic cellular protozoan parasites, and as you see in the last item in this slide, there is a tendency to induce immunity to reinfection in those hosts that survive, which means that after we get the infection, and if we survive it, and usually we survive it, it leaves behind immunity to reinfection. We don't get the reinfection again, not on the short term at least, and there is variation between one and other. Now the protozoa are divided into 5 major groups like you see here. The Sarcodyna, referring to the amoebae, Mastigophora, the flagellates, Epicomplexa, or older name is Sporozoa, which contains the malaria parasites, Celiophora, the ciliates, Balantidium, and the Microspora. Blastocystis hominis is a parasite which has not been classified within those 5 groups, so it stands out there on its own. It is clinically less significant, less common, less likely, but there it is, and we encounter it every now and then. Now, this is a table of the medically important protozoa, human parasites. And as the title up there over the left side shows, the major and minor pathogenic protozoa. And those are the major protozoa on this slide. We have in the intestinal tract, we have got Entamoeba histolytica, Giardia lambelia, Cryptosporidium parvum. In the urogenital tract, we have Trichomonas vaginalis. And then the subject of this lecture are the blood and the tissue protozoa. In here, we find at the top of the table in the middle, we have got Plasmodium species, and I write next to it in red RBCs. Plasmodium species infect the red blood cells, and this is what malaria is about, which we shall talk a little bit about during this lecture, but more later on in the TBL session. And at the end of the slide down there, we see Babesia microti, again in the RBCs. So for the blood protozoan parasites, we have got 2 main parasites: the important malaria, Plasmodium species, and the minor or the rarely encountered Babesia microti. Then for the white BCs, usually those protozoan parasites occur in the white BCs. Interestingly, if you notice, here we have got a parasite that lives within the white blood cell. And as you must already know about the white blood cell, it is the first cell that encounters the organisms and microbes. It usually phagocytoses those microbes, it digests them, and then it presents component of those microbes on the surface for the immune system to respond to and to form immunity against them. But here we find that those protozoan parasites live within the white blood cells. And we can see in this table Toxoplasma gondii, Pneumocystis jirovecii. This Pneumocystis jirovecii has been identified as a fungus rather than a protozoan parasite. That's why I put it aside alone, and we shall mention it later on. But we come to Trypanosoma species and Leishmania species, which live in the white blood cells in the tissues, like we shall see. Now this is for malaria, Again, I say that the epicomplexan parasite of malaria, Plasmodium species, lives in the red blood cell. Now, if you remember, the red blood cell is a cell that has extruded its nucleus. It's quite an inert cell, actually. And the main function of the RBC, you may guess that it will be the transferring oxygen, carrying oxygen from the lungs to the tissues, and then carrying back carbon dioxide to the lungs to be exhaled. So when the parasite comes, the Plasmodium parasite comes to invade the red blood cell, it cannot be taken up by phagocytosis. The RBC, there is no phagocytosis in the RBC. But what happens rather, if you look at the red colored RBC in this slide with the parasite drawn in blue, you notice we have got numbers 1, 2, 3 up to 6 or 7. You notice that the parasite comes to dock. Actually, it attaches to the RBC membrane. It's like a ship docking at the port, and then it reorients itself so that the apical complex, as its name means, will start to penetrate the red blood cell by physicochemical actions, whatever it is, will not go into the detail, and then this parasite inserts itself. It invades the red blood cell, and you notice that inside the RBC there is a yellow rim around the red blood cell. Actually, there is a membrane that is taken up, part of the membrane of the RBC, that forms what we call as a parasitophorous vacuole. It's like a parasite where it's like a vacuole where the parasite lives inside it. So it is protected as well within this parasitophorous vacuole. And you can see it on the right-hand side in a detailed description, which you are not responsible for, only to tell you that the parasite invades the red blood cell one way or the other. Now, the Plasmodium species, we have got 4 main human Plasmodium species, human malaria species: Plasmodium falciparum, vivax, ovale, and malariae, like you see here. And the 5th species down in the slide is Plasmodium knowlesi. Knowlesi, we pronounce it without the K, actually. It's Plasmodium knowlesi. It occurs in monkeys, which means that it is a simian Plasmodium parasite. It refers to the malaria in monkeys, monkey malaria. But this parasite has got the capacity to infect humans as well. And this is the most recent addition to those human parasites, actually, because it occurs in Southeast Asia, and because man has invaded into the tropical forests there, and as men went inside the forests, they became infected with the simian monkey parasite, and we now know that in Southeast Asia, Plasmodium knowlesi, yes, does infect humans and produce infection in those areas. This is a map of the distribution of the malarial parasites in the world. If you notice in the upper map, in red color, you can notice the areas which are endemic for malaria. Looking at Africa, we notice that all of tropical Africa, or what we call as the sub-Saharan Africa, is all infested with malaria. Like in the Amazon basin in South America, the red patch there in the heart of South America refers actually to the Amazon area, the Amazon basin we call it, plus some other foci here and there, of course, and in India. Now, the better slide, actually, the better map is the one that you see in the lower half of this slide, and you notice that in Africa, around the borders of tropical Africa, we have got some area in pink, which means that there is malaria in there, but it is not as stable and as endemic as in tropical Africa. Similarly, in the Amazon basin, the peripheries are less endemic, of course. And if you look at India and at Southeast Asia here, malaria is distributed in different foci. Generally, it occurs in rural areas, more in rural and forested areas, rather than in the modern and urbanized cities. Importance of malaria, it's very important, of course. I go directly to the lowest line in here, that it could be the most important to tropical disease. You can read the rest of this slide and we'll come back to malaria anyway. And malaria in endemic areas is mainly a disease of children, and it causes the death of children usually before the age of 5. And as you see on this slide, here we see a picture of healthy young children in Africa, African children. And as the comment down there shows, is that those are healthy and they are like partly immune to malaria. They can have it on board. If you look for it, you may be able to find it, but it does not produce clinical disease. This is because they are largely immune to malaria, as they are living in the endemic areas. Similarly, adults will be relatively and largely immune to malaria. This is also my picture of some children in the Amazon basin. Again, those children are most probably partly or largely immune to malaria. Okay, this is the mosquito, the Anopheles mosquito. This is the vector of the Plasmodium parasite, and you can see that the belly is engorged with blood. That's what the mosquito, especially the female mosquito, needs for the maturation of its eggs in her ovum, actually, so that it can reproduce effectively. And this is the life cycle of malaria. First it goes to the liver, and then it goes to the RBCs in the blood to produce symptomatic malaria, which I said that we'll come back to later. But you can look at the slide. This is very interesting and quite true. This is on a peripheral smear. If you get a patient coming from Africa or from an endemic tropical area like in South America, Southeast Asia, and they have fever, then malaria will be in the differential diagnosis. You take a blood smear and you may see those rings. We call them rings. Actually, as the Plasmodium parasite invades the red blood cells first, it transforms into rings within the first few hours after invasion of the RBCs. So the ring stage is common to all of the Plasmodium species. And like you see here, the nucleus forms the dot in the ring, and then the cytoplasm makes the periphery of the ring as well. We'll come to those. And here in schematic diagram as well, you can see that in the upper row, actually, that the ring stage is common to the different species of malaria: Plasmodium falciparum, vivax, ovale, and malariae. And then this ring will enlarge, it will metabolize and enlarge, it will grow into a trophozoite, and then this trophozoite will divide to produce the schizont containing those multiple merozoites. And each merozoite, like you see here, when the RBC ruptures, can invade or infect a new RBC. Some, you can see also the arrow going around those schizonts, because some of those rings and trophozoites will not develop into schizonts, rather they will develop into the gametocytes. Why? Because they have got to conserve the species and produce gametocytes, which will mature and become gametes and fertilization within the gut of the vector, the Anopheles mosquito. Chloroquine-resistant Plasmodium malariae, Plasmodium falciparum malaria, of course. We live in the era of drug resistance, and here we have chloroquine resistance. And then the drugs that are used for malaria generally are, like you see here, the drug of choice is an artemisinin derivative in combination with other antimalarial drugs. Atovaquone proguanil is another fixed dose combination called Malarone, and this remains very good and very effective. Mefloquine, Lariam, with other antibiotics or with other drugs as well. And then a quinine-based regimen as well can be used. Those are the 4 alternatives that can be used in treatment of malaria. They are quite effective, and as you may notice, usually in combination, not one drug alone, usually in combination. Prevention and control of malaria, if we can avoid bites by the mosquitoes, that will be very helpful. So we can use bed nets, or we can use long-sleeved clothing, which means, you know, the clothing that covers the arms and the legs. And we can apply insect repellents as well on whichever exposed part of the skin, in the legs, in the arms, around the neck or face. Insect repellent is very helpful. As you can see, there is nothing absolute to prevent malarial infection in endemic areas, but we can make use of all of these items. Drug chemoprophylaxis, also some of the drugs I mentioned can be taken for the prevention of malaria as you go into an endemic area, or as a traveler will be visiting tropical areas. Chemoprophylaxis can be given. Removing breeding sites, larvicides, and insecticides, which means that if you can decrease the population of the mosquitoes, that will be very helpful with whatever mechanisms mentioned here. And vaccines, the vaccine remain in development. Actually, ever since I studied parasitology, about 30 years ago or so, some people were working very actively on the vaccine, but still 30 years later we don't have vaccines yet. Another group of parasitic protozoa, like I mentioned before, are the Babesia. You can go over this slide and look at it at your leisure. Okay, Babesia is transmitted not by the mosquito but by the tick. What you see in the right lower corner in this slide actually is a tick. I think that this is rather a soft tick, and a tick is an arachnid. If you notice, it has got 4 pairs of legs. This is like spiders. Spiders are arachnids, whereas mosquitoes, البرغش, are insects, insecta. This is arachnida. So here we have got the tick, which transmits infection with Babesia species, and also another one is called Theileria species. You notice here that in the RBCs there are rings, but they are not the typical rings like we saw with malaria. So if you find some rings in RBCs and they are not that typical of malaria, think of Babesia as well. This is associated usually with animal farming, cattle, sheep, goats, and others, which are infested by ticks, of course, and the tick may transmit the infection to humans taking care of those animals in the farm. Now you can have a banana. Notice the red bananas in Africa. Interesting. This is in Cotonou, Benin, and that's where Benin is next to Nigeria. Okay, so we go on with the mastigophora, and in the mastigophora we have the flagellates, and under the flagellates we have got intestinal and genitourinary flagellates that we mentioned before, Giardia and Trichomonas, and the blood and tissue flagellates, those are Leishmania and Trypanosoma. This is a trypanosome, which is a flagellate. You notice the flagellum at the end over the right hand side, and the flagellum is usually an attachment organ rather than a propelling organ. It's an attachment part. And we mentioned that protozoan parasites are eukaryotic organisms. You can notice that it is one cell. This protozoan trypanosome parasite is unicellular, and it has got the characteristic cellular organelles, like you can all see very well depicted. Interestingly, it has got a big mitochondrion that spans the whole body, and there is the mitochondrial DNA over the left hand side, the uppermost word, the kinetoplast, and those are helpful in identifying those parasites in the patients. Okay, we start with Leishmania. The disease of Leishmania. Okay, Leishmania is a zoonotic infection, which means that it's an infection that occurs in animals, usually rodents and canids. Okay, rodents like rats and mice and similar animals, as well as canids, which means, of course, dogs, foxes, and similar animals. This is the main animal reservoir, and this is where Leishmaniasis occurs mostly in nature. Now, except for one species, which is Leishmania donovani, subspecies donovani as well, and this produces the disease of Kala-Azar, which means black fever in Indian, and that occurs in India and it has no identifiable animal reservoir. Man only. Man is the reservoir. And that occurs mainly in India. Now, the sandfly is the insect vector which you see on the right-hand side, and there is importantly possible reactivation with subsequent immunosuppression. So here, not with subsequent infection, rather with subsequent immunosuppression. And don't forget that immunosuppression is becoming more common nowadays, especially with our chemotherapeutic agents, with our radiotherapy, with our biologic treatments, our steroids, and also, of course, our infection with the HIV, which may produce immunosuppression. Those are the reservoir. The canids, you can see a sick dog in here with large claws, you can see over the left-hand side. And then we have got the rodents. And what I mean here is that it's not only the rats and mice, but other rodent-like species, which we know or we don't know in different geographic areas in the world. Now, leishmaniasis. The disease is divided into three parts. We can have first cutaneous sores or ulcers. This is disease limited to the skin only. It produces ulcers on the surface of the skin and usually on the exposed areas like the face and the hands mostly, and over the ears as well, of course. Then we have mucocutaneous lesions, and this comes to the nasopharyngeal area that is behind the nose and the mouth, behind the nose and in the pharynx. Okay, mucocutaneous lesions, and that occurs with Leishmania brasiliensis only, and we'll come to describe that. And third is the systemic disease or visceral leishmaniasis, which involves the viscera or the internal organs. Mainly, it's the liver, spleen, and lymph nodes, the reticuloendothelial system. And in this picture, you can see the cutaneous ulcer. You can see destruction of the nasal mucosa and the tissues inside. And third, you can see as well the large hepatosplenomegaly in this young African boy with visceral leishmaniasis. So here we have got a protozoan parasite, Leishmania. It belongs to the Kinetoplastida. It has got a kinetoplast, of course, and it is transmitted by the sandfly. Transmission, this is the sandfly vector. It's a small mosquito, 2 to 3 millimeters in size. It's fragile and it flies at low altitude, and it lives around shrubs, which are small vegetations, and it occurs at about 1 to 2 meters from the ground level. Those are the shrubs, and it flies at that level usually. Now, we have got two genera of the sandflies, Phlebotomus species and Lutzumia species. Phlebotomus occurs in the Old World, which means that it occurs in Asia and Europe and Africa, and Lutzumia is for the New World, the Americas. The high season refers to the season where the population of the mosquitoes and insects, especially the sandfly, like other mosquitoes as well, will become larger and denser, and this occurs in warm late summer and early fall. And you can see clearly the picture of this tiny insect, tiny mosquito. It's only about 3 millimeters in size. It's quite hairy upon this magnification, and there it is. Now, Leishmania stages, we have got two stages, promastigote and amastigote. The promastigote, as you can see in the picture up there over the right-hand side, it's elongated with a flagellum. This occurs in the vector, the sandfly. This is the infective form, and it's also produced in culture in the laboratory. Now, the amastigote is rounded, like you see in the lower panel of pictures. It has got no flagellum. It is called the Donovan body. This occurs in the mammalian hosts in man and in animals, the rodents and canids. So this occurs in the tissue macrophages or the white BCs. And you can see it clearly, especially in the central picture in the bottom of the slide there. You can see the nucleus of the white BCs. Those are the large, slightly darker rounded structures. Those are the nuclei of the white blood cells, and within the cytoplasm you can see a lot of Donovan bodies or amastigotes. Again, as just I said here, that in the mammalian hosts, in the upper panel of this slide, you can see that the Donovan bodies or the amastigotes occur, and you can identify them. You can see them within the white blood cell. And then when those white blood cells are taken up by the sandfly, we go to the lower panel. In the sandfly gut, the white BCs will be digested, and the amastigotes, the Donovan bodies, will be liberated. Those amastigotes transform into promastigotes, attach to the mucosa of the gut of the sandfly. They multiply there, they grow there to produce reinfection in the second or the next host to be bitten. Distribution of Leishmania species, mostly tropical and subtropical areas. So actually, Leishmania infection is a geographic infection. If you take the visceral form, which occurs internally in the internal organs, in the old world, the species that produce that are Leishmania donovani, like in India producing Kala Azar, and Leishmania infantum around the Mediterranean area or in the Middle East. So this is Leishmania donovani or Leishmania donovani infantum. Here we have got two species and subspecies, if you want. In the New World, in the Americas, it's in the Americas. And when we say in the Americas, this is a tropical and subtropical infection, we mean South America and Central America only, not the United States or Canada. There we have got Leishmania chagasi in South America. For the cutaneous form, in the Old World, we have got three main species, Leishmania major, Leishmania tropica, and Leishmania ethiopica. And you can see the description of the ulcers that they produce on the skin. Leishmania major produces a moist ulcer, multiple ulcers usually, and it occurs in rural areas. Whereas Leishmania tropica, it produces a dry single ulcer and in urban areas. This is the most common form, Leishmania tropica, that occurs in the Middle East in different areas in Syria, Jordan, and Iraq. Leishmania ethiopica occurs in East Africa, as its name may indicate. In the New World, for the cutaneous form, we have got Leishmania mexicana species in Central America and Leishmania amazonensis in Brazil, mostly in the Amazon basin. And then for the mucocutaneous, it occurs only in the New World, and it is produced by Leishmania brasiliensis species. And this is called the South American Espundia. Commonly they call it there Espundia, which destroys the mucosa of the nasopharynx. Now you may think or you may notice that in South America, we have got, for example, Leishmania amazonensis, as well as Leishmania mexicana and Leishmania brasiliensis. So how can we distinguish between those? Actually, we cannot. And morphologically or under the microscope or so, we cannot. So what happens is that all of the Leishmania cases in South America are treated and taken really seriously for fear that they may be produced by Leishmania brasiliensis. They try to treat them effectively, because if they are not well treated initially, then the infection will go to the nasopharynx from wherever the infection was acquired under the skin at the bite site of the Lutzumia mosquito in the New World. It will like metastasize or go to the nasopharynx to destroy the tissues in there. Definitely there is treatment. The best treatment for that is ambisome, but ambisome in poor countries is not readily available and it's not easy to treat. Okay, here there is this slide. You can look at it on your own. Just it will show you different areas. Please notice that around the Mediterranean, we have got Leishmania donovani infantum. Okay, again here you can see some of the distribution, but definitely the areas in the Middle East, there is a lot of overlap, if you notice, like in this shaded area between Leishmania tropica and Leishmania major. So we cannot know exactly the species. You have got to work on it academically, actually. It's not easy and not readily available in clinical labs. Forms of disease, as we said, visceral, the visceral form, already I described it. The cutaneous form, also I described it, and the mucocutaneous Leishmania brasiliensis. And you have seen those pictures. Actually, my slides, my lectures contain a lot of slides, but many of those are only pictures. Diagnosis. We can do bone marrow or ulcer scraping, whichever it is. Visceral, you do bone marrow aspiration. Cutaneous, you do ulcer scraping or spleen aspirate for the visceral as well, to find mastigotes, like you see on the right hand side. This is from a bone marrow aspirate. You can see a macrophage in there with the large nucleus and multiple dots there. There is nothing exactly like it actually, so the pathologist can easily suspect that this is probably Leishmania, and they will look at other fields to identify as well other mastigotes and Donovan bodies. The serology, antibody antigen detection can be helpful. PCR testing also, wherever or whenever available, but it tends to be more expensive. And rarely culture. Culture is usually done in research laboratories, in academic centers only. Chronic disease with fever and wasting, hepatomegaly and splenomegaly, those are the clinical manifestations of visceral Leishmania. And pancytopenia, that is whenever you do a cell count or a CBC complete blood count, you may find anemia, a low hematocrit, leukopenia, low white BCs, and thrombocytopenia, low platelets. Treatment, as I mentioned before, liposomal amphotericin B is a drug of choice. If not available, then pentavalent antimony drugs, and they do have some side effects, so they are not very nice. Examples of those are like sodium stibogluconate or meglumine antimonate. Both are IM or IV for local injection for cutaneous ulcers as well. So they are not very easy to use, and they have to be given for about a month. So injections for a month are not easily and readily available for people living in rural areas in those endemic tropical and subtropical areas. A skin test called the Montenegro test. It's usually negative during the illness. It becomes positive after recovery. This is like the PPD or the Mantoux reaction with tuberculosis, but here it's the other way around. It's negative during the active illness, usually with visceral Leishmania, and as you treat the patient, it becomes positive, then it will be like a sign of recovery. So it's a prognostic test rather than a diagnostic test. Prognostic. Cutaneous Leishmaniasis is like I described before, and here you see more pictures and slides. And the mucocutaneous lesions with Leishmania brasiliensis, like I mentioned before. Again, pictures of mucocutaneous leishmaniasis. You can see the extent of destruction of the mucosal tissues around the nose and the nasopharynx. Immunopathology. You know that nowadays immunity is divided into two polarizations. That is, it's polarized, one side or the other. It's Th1 versus Th2. That is the T helper cells, either type 1 or type 2. In case of Th1 response, usually it is indicated by production of interleukin-2 interferon gamma, and this stimulates or reflects the cell-mediated immunity, which is usually protective in Leishmania, whereas with Th2 response, as indicated by interleukin-4, 5, interleukin-10, and others as well, this indicates humoral immunity and production of antibodies, and this is for the susceptible host. So what happens actually initially is that the parasite itself polarizes the immune response against it into a Th2 response. So the host will be susceptible. As the host is treated, and with time, the immune response turns into a Th1 response for the healing of the infection and for protection from reinfection as well. Vaccines. There are no vaccines yet, of course, but the old type we mentioned here, old vaccine, live inoculation but hazard of reactivation. What mothers used to do in endemic areas before is that they used to expose the lower part of the back and buttock to the bite of the sandflies in endemic areas. It's quite a smart move actually, because it will produce infection at a hidden site on the surface of the skin, especially in young women and in young men, so that they will not have the scar of the ulcer on their face later on in life. But nowadays we know of reactivation, the hazard of reactivation, and this practice is not encouraged, of course. But we should find a better vaccine for them. We don't have a vaccine, so it's mainly avoidance of the infection. Prevention and control, again, like with malaria, find mosquito nets, bed nets or screens, and clearing vegetations around houses, sleeping on the upper floors, because the sandfly usually flies at a lower altitude, as I said, 1 to 2 meters. So sleeping on the upper floor at night will protect you relatively, partly, and insect repellents are also good. And here, a tiny more detail about the insect repellent if you come to travel. The DEET, or the diethyl tolbutamide, actually, it should be at a good concentration of 30 to 35% to protect you for the 8 hours of the night. Otherwise, the protection will be more limited. Picaridine is the European insect repellent, and it is much better tolerated on the skin and less staining for the clothes as well at this particular concentration. The mastigophora, this is leishmania, and then the trypanosomes. We have the trypanosomes as well. And in the trypanosomes, we have got partly in Africa and the other part in America. Let's go and see. First, we go to Africa. Okay, fasten your seat belts well. And there we have got trypanosomiasis. If you look at the map of Africa, it's mostly in tropical Africa, of course. And there we have got a big fly on a drone or pictured on tropical Africa, and we shall examine this fly together. Watch out that it will not bite you while there. Trypanosomiasis. Trypanosomes are hemoflagellates order Kinetoplastica. So again, we are talking of the mastigophora, the flagellates, typical trypanosome. African trypanosomiasis, or sleeping sickness. Sleeping sickness. Now, why the sleeping sickness? Because actually it can produce a meningoencephalitis. A meningoencephalitis. All right, so this will tell you, but I shall tell you later how does it end up with meningoencephalitis. But the cause of the sleeping sickness is meningoencephalitis. And actually it's produced by 2 types of those parasites, Trypanosoma brucei gambiense and Trypanosoma brucei rhodesiense. Let's go there. This is the vector. This is called the tsetse fly. Again, the second T is not usually pronounced. It's called the tsetse fly. Which means that the first S is not well pronounced. Tsetse fly. Yes. It belongs to the Glossina genus, so the Glossina species there, like Glossina palpalis or whatever. This is the vector. And actually this is a fly. It belongs to insects, of course, but it's not a mosquito. يعني مثل الدبانة الكبيرة. And its size actually usually is about 1.5 to 2 centimeters, so it's a big fly. All right. And that particular stick that you notice protruding from its head is the proboscis. This is the proboscis, or the mouth. This is like a straw through which it sucks the blood from the blood vessels whenever it's taking a blood meal from man or animal for that matter. Now, this is a much better map and picture, because trypanosomiasis, African trypanosomiasis, is not all over tropical Africa. It is in particular foci, usually in the rural areas. And we have got in the yellow color that you notice here, yellow, Trypanosoma brucei rhodesiense, mostly in East and Central Africa. And then in blue color, Trypanosoma brucei gambiense, in blue color, and this is in Central and West Africa. Okay, so this is the geographic distribution. Now, how does the clinical illness start? It starts with a trypanosomal quote-unquote chancre, which appears about a week from the time of the bite by the tsetse fly, by Glossina. This occurs at the bite site, painful papule, 2 to 5 centimeters, like you may see here, spontaneous resolution within few weeks, and this is much more common. That is, this chancre is much more common with the rhodesiense variety rather than the gambiense variety. Then the second stage is the hemolymphatic stage, which means that the parasites, after multiplying locally at the site of the chancre, they disseminate or they go into the bloodstream and into the lymphatics as well. And this corresponds to the hemolymphatic involvement. And there it produces periodic high fever with parasitemia, which means the presence of the parasite in the bloodstream. So hence we can take, with this parasitemia, with the fevers, we can take a blood sample and check for the presence of the parasites. There will be, of course, immune evasion and progression of the infection. This particular phase, the second phase, is shorter and more severe with Trypanosoma brucei rhodesiense, and it's longer and milder with the gambiense variety, which means that the rhodesiense is shorter but more violent, whereas the gambiense is longer but milder in illness. Now, the winter bottom sign, which corresponds to a posterior cervical lymph node, is much more common with the gambiense variety in Central and West Africa. Gambiense. And this is for the winter bottom sign. You can see the enlargement of those lymph nodes, okay, posterior cervical lymph nodes, taken as the winter bottom signs in the second phase of trypanosomiasis. Now, how do we have the immune evasion with this parasite, which lives actually within the white blood cells in the tissues? Here you can notice that what we have is the variant surface antigen, like a coat on the outside of the parasite, and this coat is changed like every week or so. So the parasite will express certain antigens on its surface for 1 week, and then it will change that antigen. So by the time the immune response aims at that antigen and tries to nullify it or to kill the parasite by attacking those antigens, it sheds off this variable surface glycoprotein or coat and puts on another coat. That's why you see on this slide those curves in different colors, one after the other. This corresponds exactly to the antigenic variation in African trypanosomiasis, and this is how the parasite evades the immune response and keeps on escaping from it until the time comes and we go into the CNS invasion, and this is the third stage of the infection. Here the trypanosomes go to the brain and the cerebrospinal fluid, and they can be seen in the cerebrospinal fluid, and as they go there, they produce inflammation corresponding to meningoencephalitis, which means inflammation of the meninges and the brain tissue encephalitis, ME, meningoencephalitis. It produces clinically headache, mental changes, sleep disorders with sleepiness, hence the sleeping sickness, progressive deterioration of consciousness to coma, and this occurs rapidly within weeks to months with the more severe, more rapid rhodesiense variety, and slower, taking months to years with the gambiense variety. Hence, we have got the rhodesiense variety, which is much more severe generally and much more rapid, and it occurs in Eastern and Central Africa. And then we have got the gambiense variety, which is milder and more chronic, and it occurs in Central and West Africa. Diagnosis: aspirate from the chancre, if we can find a chancre or a lymph node where we can find the trypomastigote. Peripheral blood smear can be helpful, but concentration techniques have to be done and better preparation. Serology may be helpful. If we do a lumbar puncture for somebody with a disturbed consciousness, we may find the trypanosomes in the CSF. We may find also lymphocytes, elevated protein, IgM antibodies, and the morula cells. Like you see in the lower right-hand side, the morula cells are like a a young ovum with early division of the cell like you see here. Those morula cells are rather pathognomonic, highly suggestive of African trypanosomiasis in the CNS. Treatment early, that is within the first and second stage, pentamidine or suramine. Late stage, that involves the CNS. Again, those names coming from outer space, eflornithine, DFMO, or melarsoprol, but those are toxic drugs and they are not easy to administer to the patient. And also the illness may relapse after years with chronic meningoencephalitis. Reinfection also can occur. Control, again, the same themes. Vector control of the tsetse fly by tsetse traps, actually, because this is a big fly. And you know that flies fly during the daytime rather than mosquitoes that fly and bite at nighttime. Human treatment, of course, animal reservoir control, and insect repellents are all helpful. Those are the tsetse traps. They are very simple. They are made up of clothes which is not repellent to the tsetse fly, and what they do is that they put inside a chemoattractant, a chemical that attracts those flies by its smell, and the cheapest thing to put there would be the cow's urine. Some urine from the cow, you put it inside so that the tsetse fly will home into this trap. It goes inside searching for the area where the smell is coming from, but it is built in such a way is that it cannot go out. And those traps in endemic areas can be very effective, actually. Next, please again fasten your seat belts to go to South America for American trypanosomiasis. Now, American trypanosomiasis is also called Chagas disease because Dr. Chagas has discovered it, Chagas disease. And as you can see on the right upper hand side of the slide, we have got the highly curved trypanosomes with a prominent kinetoplast. Okay, you see that the nucleus is in the middle of this crescent-shaped parasite. This is the dark nucleus, and then at the periphery, at the tip, we have got the darkly staining, large, prominent kinetoplast as well. This is typical of American trypanosomiasis. It is caused by Trypanosoma cruzi. Trypanosoma cruzi. It's highly curved C or S shaped, okay, with a large dark kinetoplast like I described. Now, the illness there is the leading cause of cardiac disease in Central and South America. Wow, God, here we have got a parasite that produces cardiac disease in the heart. How does it produce cardiac disease? Let's see. This is a map of South America. It's nice to know some geography. And please look at the Amazon basin in there, just for you to know where it is. It starts from around the area of the Andes at the western border of South America, and then it flows to the east, to the Atlantic Ocean. The vector of American trypanosomiasis is the triatomine bug. The triatomine, commonly called the triatomine bug, and this is called the kissing bug as well. Belongs to the genus of Rhodinus, like you see here. Well, however, we are not interested very much in the names, but here you can see a bug, not a fly actually, not like the tsetse fly, but this is a bug, and it can be large. It can be between 1 and 3 or 4 centimeters. It's quite big, actually. And you see that the mouth part is even larger than the proboscis of the tsetse fly. But still, it is called the kissing bug. It usually lives in mud cottages, okay? In mud cottages, like I hope that I have a picture to show to you. And it is transmitted. This is the major vector for American trypanosomiasis. Also, it's transmitted via blood transfusions and local transplants in South America, of course. Okay, this is the bug. For you to appreciate the size of that bug, please compare it over the right-hand side. Compare it to the size of the adult nail as well. The nail is about 1.5 to 2 centimeters maybe, and here you can appreciate the size of the triatomine bug. Still, it is called the kissing bug. Why? Because usually it falls off to the bed at night from the mud floor or from the mud walls or mud ceiling, it falls off onto the bed and then it crawls slowly. Usually it comes to the face and it likes to bite around the eye. So like you see in the pictures of this slide of this child in here, it produces the bite around the eye, and it's called the kissing bug because before it bites it starts to inject a local anesthetic in its saliva. So it anesthetizes the area a little bit and then it starts to suck the blood. As it injects its saliva with the local anesthetic there, if it is infected with the trypanosome and it is a main vector of the disease there, it will inject also some, it will not inject. Actually, it produces the bite site there, but usually while feeding with blood, it defecates from the other end. It defecates on the skin, and then some itching is produced in the area, and the child scratches the area, or the person scratches the area and easily physically transfers those trypanosomes into the bite site, and this is how people get infected. So the incubation there is at least 1 week for the swelling to produce like that, the chagoma or romana sign, swelling around the eye, and this is also associated with some fevers, facial edema, and local lymphadenopathy or enlargement of lymph glands. Clinical feature, later it produces fever, lymph node enlargement, hepatosplenomegaly, myocarditis in some cases, but it can be serious, and the symptoms resolve spontaneously. Why the myocarditis? Because this parasite usually goes to the autonomic ganglia of the nervous system. You know that we have got the autonomic nervous system with the ganglia, and those ganglia are present in our visceral organs, like the GI tract and like the heart as well. So this parasite goes to those ganglia in the heart and in the GI tract. Hence, it can produce myocarditis and affection of the GI tract that we'll come to later. And then on the chronic phase, there will be cardiac involvement after years, hence the cause of cardiac disease that I will describe as well. And in the gastrointestinal system, we have got the mega disease like mega colon and mega esophagus. Different infectious complications usually contribute to the death of the patient. And those are pictures that show you the cardiomegaly. Why the cardiomegaly? Because the nerves of the heart are affected, because of the affection of the autonomic nervous plexuses in there and the muscles of the heart. Hence the myocarditis, where the end stage of that will be dilatation of the muscles and congestive heart failure with cardiomegaly. And over the right hand side, you see the enlarged esophagus. The esophagus here, by barium contrast imaging, the esophagus has trapped a lot of the barium in the esophagus. It is not transmitting it effectively into the stomach, hence the call of mega esophagus that reflects a dilated esophagus. Why? Because the autonomic nervous system there again is not functioning well. The esophagus is an important active structure in the body, or organ, and it helps move the food downwards into the stomach by regulated peristalsis. The toxic megacolon, the colon can be affected also, and by affecting the nerves of the colon, by affecting the autonomic nervous system, the colon will become dilated, it will become lazy and not contracting, and you see over the right hand side all of this dark air in the colon. It depicts the whole colon from the right lower quadrant in here over your left hand side, right lower quadrant up the ascending colon, then we have the transverse colon to the splenic flexure, which does not show very well here, and then it goes down the descending colon into the sigmoid area. But we don't see air in the rectum in this particular x-ray. All right. Those are sections of the affected heart muscle with amastigotes in pseudocysts in the heart muscle. So as I told you that it goes into the autonomic nervous plexuses in the heart, and you can see like pseudocysts, which means collections of those parasites, not in a typical cyst, but in a rather pseudocyst without specific walls or membrane around the cyst. And the dark spots which you see around there are the nuclei of the white blood cells, which are the inflammatory cells. There should not be that much of white BCs in this muscle section, and the presence of those white BCs in there, as reflected by the staining of their nuclei, reflects that this myocardium part is inflamed with chemotaxis and migration of the white BCs in this area. So here we have got inflammation of the heart muscle and myocarditis, of course. And over the right-hand side, you can see those pseudocysts with the amastigotes inside. And within those small circles at the tips of the arrows, you can see the amastigotes or the Donovan bodies, and they are typical. A darkly staining nucleus and a small, also darkly staining kinetoplast. This is typical, and pathologists can identify it very efficiently and confidently. Diagnosis. Peripheral blood smear, especially concentration methods. Why? Because you have got to concentrate the blood to catch the parasite, usually. Serodiagnosis can be very helpful by looking for different kinds of antibodies, IgG and IgM, and by different techniques, of course, to capture those antibodies. Treatment. Nifurtimox and benzimidazole have severe side effects as well. So again, like you see with African trypanosomiasis, the American trypanosomiasis is not very easy to treat. Those drugs are rarely used except in endemic areas, and they have got severe side effects, which is a limiting factor in treatment. Control, again, the same theme occurs here. Improved housing conditions, controls vectors, mosquito nets, insect repellents, blood banking. This is a new item in the control because in South and Central America, they have got to be careful about screening blood units for the presence of trypanosomes in them. And then congenital infection can occur, and it needs careful diagnosis and treatment as well. Okay, and then just to continue lastly in a couple minutes, the minor protozoa. Here we have got in the intestinal tracts, and I shall read in the middle under the species Balantidium coli, Isospora belli, Enterocytozoon biennusi, Septata intestinalis. Those are the microsporidia. They belong to the microsporidia on the right hand side. We have got Cyclospora cayetanensis as well. Blood and tissue, we have got the amoebae, the free-living amoebae, Naegleria species, and Acanthamoeba species. Babesia we have mentioned before in the RBCs, and we know that. Microsporidiosis, clinical features. Human microsporidiosis represents an important and rapidly emerging opportunistic infection, which means that with the modern immunosuppression, it is occurring much more than before, and hence it is considered as an emerging new disease, but mostly in immunocompromised patients. Clinical manifestations are diverse, mainly diarrhea being the most common. Okay, then the free-living amoebae. Those amoebae, they are free-living. They can live in the soil and water, and they can usually contaminate fresh water, like freshwater ponds in nature, like you see in this nice picture down there. So those ponds may be contaminated by the free-living amoebae. Infection by those are the names of the genera there, Naegleria, and more common than by Acanthamoeba. So we have Naegleria and Acanthamoeba, and rarely Balamuthia. I like the name of Balamuthia, Balamuthia mandrillaris. It's a bubbling name, Balamuthia mandrillaris. But that occurs in very restricted areas. Don't worry about it. Okay, here we have got the life cycle of those free-living amoebae. The only thing to remember about them is that they occur usually in aquatic environments and in contaminated water, like water ponds in nature or neglected swimming pools, neglected and contaminated swimming pools. So whenever you swim, you have got to know where you are swimming. You better swim with a buddy.